Hello everyone, welcome to my channel, and today we will be discussing a very important topic, a topic that I have selected from GIT, and this is a topic for all the surgeons, for all the residents, for all the MBBS students. This is a less, you can say, understood, more confusing topic. Everyone knows it's a very popular topic, but a lot of students are confused. So let me show you one pic, and then you can actually make out what it is. So this is an image of an upper GI endoscopy, and this is something which is seen in the esophagus. So you are seeing esophagus in front of you, and you see a classical picture like this. So what do you think is this all about? So you can confidently say, sir, this is esophagitis. I will also agree, yeah, that is esophagitis. But yes, there is abrasion all over the esophagus. So basically, when you are talking about a lot of abrasions and lot of esophagitis, you always take a biopsy. And if you see this biopsy, you can see something very particular, very particular. So there are some goblet shaped cells here. Yes, students, you are guessing it right. So the diagnosis that we have is a classic Barrett's disease. So there could be a lot of things. It could be intestinal metaplasia, it could be simply esophagitis, it could be non-erosive versus erosive, lot of things we have. So today's discussion is on the Barrett's esophagus. So when we talk about Barrett's, it's a very simple topic, and it's very easy. In 5 minutes we shall learn to understand everything about Barrett's esophagus. Now when we talk about Barrett's esophagus, what are the important things that you need to understand? Barrett's esophagus is nothing but, I can say, it's end stage GERD. So it's a end stage GERD, which is very simple thing to understand. But now let us be more illustrative in this. We are talking about Barrett's. What is the classical definition of Barrett's? It is defined as any length of esophagus. So it's not the length dependent, it is length independent. So any length of esophagus lined by columnar epithelium. So columnar, normally what epithelium do we have? We have squamous epithelium. So any length of esophagus lined by columnar epithelium with goblet cells. Now this is what is very important. So with goblet cells on biopsy. Do you know this goblet cell word is itself very important. So goblet cells on biopsy, this is what is making it very special. Now in a layman's language, you know that it is the squamous epithelium which is predominant, and then we have the columnar epithelium. So do you know there is something which is known as squamo-columnar junction? Normally it is roughly 1 to 2 centimeter above the G junction, basically the classical G junction. But here if you see, there is upward migration. What we classically see on you can say upper GI endoscopy is upward migration of squamo-columnar junction. This is what is making it very special. Upward migration of squamo-columnar junction, or you can also say that it is upward migration of ora serrata, or you can say upward migration of Z line, that is the squamo-epithelial junction line. Now when we are talking about the Barrett's esophagus, we got to understand the basic layout of Barrett's. Now there are a lot of terminologies which are to be associated. What is a short segment Barrett's? So a short segment Barrett's esophagus is defined as less than 3 centimeter. Then what is an ultra short segment Barrett's esophagus? This is less than 1 centimeter. Then we have long segment. Barrett's esophagus. This is defined as more than 3 centimeter. You know, Barrett's is a pre-malignant lesion. So you have to understand that Barrett's will often lead to what? It will lead to adeno-CA. So there is a very high risk of adeno-CA, and it is considered as a pre-malignant lesion. Now try to understand what are the types of various Barrett's esophagus. So when you talk about the Barrett's esophagus, we have 4 classical types of Barrett's esophagus. So first one, and this is straightforward from main goal. The first one is Barrett's esophagus without atypia. So Barrett's esophagus without atypia, there are no atypical changes, point number 1. The second is Barrett's esophagus with atypia. So Barrett's esophagus without atypia and Barrett's esophagus unknown for atypia also, there is one more thing. So Barrett's esophagus unknown for atypia, unknown for atypia. Then the third one that we have is a low, you can say low grade lesion. So we say LGD, low grade dysplasia, LGD, low grade dysplasia. And then we have something which is known as HGD. What do you mean by HGD, students? High grade dysplasia. So low grade dysplasia, high grade dysplasia, these are the end stage, you can say, lesions of Barrett's. So low grade dysplasia, high grade dysplasia, this is what we actually see. Now try to understand, along with that, let us try to make out what is their management. So the Barrett's esophagus without atypia or unknown for atypia, you go for anti-reflux therapy. So PPIs, long-term PPIs. So anti-reflux therapy is what is their management, and along with that, you also need to understand that we need a follow-up. So annual upper GI endoscopy. So annual upper GI endoscopic follow-up, and remember this is unless two negative endoscopy. So if you have endoscopy as normal, okay, so next year again you will follow. So this is annual. When you talk about low grade dysplasia, what is the management? Again, students, you need to understand that you have to go for anti-reflux therapy, and along with that 6 monthly endoscopic follow-up. So 6 monthly endoscopic follow-up, this is what is very important. And then we have high grade dysplasia. Now when you talk about high grade dysplasia, before you confer it a high grade dysplasia, one very important thing that you need to understand is that repeat. So you have to start with anti-reflux therapy. So anti-reflux therapy is what is the first line management, and repeat upper GI endoscopy after 3 months. Now this is what is very important in decision making. So after 3 months you will repeat upper GI endoscopy, and now on upper GI endoscopy, if the diagnosis is still the high grade dysplasia, now you need to plan intervention. Now this is what is very important. You need to plan intervention. If it is malignancy, you know you will manage it like with like esophagectomy done for ECA esophagus. But if it is still the, you can say, high grade Barrett's esophagus, then what is the next thing? You have two things. You have EMR, that is endoscopic mucosal resection. So endoscopic mucosal resection, this is one thing. And we also have something which is known as you can say ESMD. So what is ESMD, students? EMR is endoscopic mucosal, ESMD is endoscopic submucosal dissection. Submucosal dissection. So endoscopic resection and endoscopic submucosal dissection, these are very important things. When you talk about intervention, on the other side we can have radio frequency ablation also. So RFA, radio frequency ablation, and we have a device which is known as Hello 360 and Hello 90. So we have Hello 90 also and Hello 360, which are actually a device like a, you can say, a fiber which is having a glass bulb inside, and then you can, this is a 360 filament, this has a 360 degree filament, this can ablate, or it is a 90 degree you can say instrument designed to mount on the, you can say, cable of the upper GI endoscopy cable, and you can use it. So students, this is what is very simple in a nutshell. What is Barrett's esophagus? It's a pre-malignant state where you have a columnar epithelium with goblet cells. So those who still don't know what is the appearance on upper GI endoscopy, this is what, and on biopsy you get to see classical goblet cells. So this is what is very important. So just like a routine practice, I'll keep on getting many small videos for you. So do subscribe to my channel, do share it with your friends, and do comment in the comment section what topics do you want me to record for you, what are the things that you want me to revise with you, or whether you liked or didn't like the topic. So thank you. Keep on watching me.